Да,
могут просмотреть его.
давайте. Все, я тогда нажимаю, да?
Я нажимаю запустить.
Да.
И
Вот это колесико, да?
Да.
Этилик and ethanol. Ethylic spirit. In contact with blood on the mucus, need to carefully hand, according to St. And this stage include on mucous membranes of eyes, rinse with a solution of potassium permanganate in water in ratio 1 per 10,000. It means solution prepared extempore. For this 10 mg of this drug was dissolved in 100 ml of distilled water. When hit in mouth, throat, rinse with 70% of ethanol or 0.05% solution of potassium permanganate. For this step, usually perform prepared extempore 50 mg of potassium permanganate dissolved in 100 ml of distilled water. When hitting the nose, rinse laboratory 0.05% solution of potassium permanganate. In case of injury, it's mean injection, use tools necessary according to St. Pin. Quickly to take gloves off. To squeeze blood from injection site. If it's not or not stop to bleeding for 2 minutes. Wash hands under running water with soap. Hand washing the skin with an antiseptics, 70 alcohol ethylic. The injection site to handle a 5% solution of iodine and after drying to process a second time also. Close to the injection site or injury by antiseptic bandages. Put on new gloves. Be sure to inform and make the log and try. Accounting emergency employees. In case of contamination of medical personnel, biological fluids is used for emergency decontamination, means of emergency first aid kit. This kit includes ethylic alcohol, sample of potassium permanganate in 50 and 10 mg, distilled water 400 ml, solution of iodine alcohol in your 5%, dressings in your sterile balls, wipes and bandages. Eye drop 2 pieces, bactericidal plaster, items general purposes, thermometers, harness, ammonia, and sterile gloves. Remember, in order not to become subject to occupational diseases, the medical staff is necessary, first of all, to comply with safety rules in whatever department he was not working, and to consider each patient as potentially infected with disease such as hepatitis, tuberculosis, and AIDS. This picture demonstrates attacks by viruses on immunocompetent cells. Typical view of developed picture of AIDS, acquired immune deficiency syndrome. Typical biological targets in organisms include brain macrophages and glial cells, lymphatic nodules and pathways, thymus, bone marrow, lungs, skin, Langerhans cells, and bowel. Clinical classification of HIV infection include 5 periods. Incubation lasts 4 weeks up to several months after infection. Primary clinical manifestation, usually fever, polydenitis, pains in joints, serous rash on skin, enlargement of liver and spleen. This period usually lasts within 3 weeks up to and regress suddenly. Next stage, latent. Absence of subjective and objective signs. May last up to half of a year up to 10 years. Secondary clinical manifestation period is characterized with gradual, during several years, transformation up to AIDS-associated signs: fever, polydenitis, hair leukoplakia, pyodermitis, mycosis, viral dermatosis with chronic cause and resistance to therapy, weakness, fatigue, night sweating, long diarrhea, decrease of body weight not less 10%, shifts of blood tests, leukopenia, anemia, thrombocytopenia. And terminal stage, stage number 5, occurrence of opportunistic infection, malignant tumors, and considerable more than 20% decrease of body weight, up to cachexia. Clinical forms of terminal stage of AIDS may last in view of pulmonary, gastrointestinal, dermal, cerebral, disseminated, and non-differentiated. Pulmonary form may be in view of occurrence of pneumocystic pneumonia. Gastrointestinal, more distributed in view of occurrence cryptosporidis. Dermal, occurrence of Kaposi sarcoma. Cerebral form, occurrence of toxoplasmatic and cryptococcal meningitis. Disseminated, with involvement of lungs, skin, digestive tract. And non-differentiated in view of long fever, weakness, cachexia. Criteria of AIDS subdivide criteria of human World Organization based on great and small signs. Great signs: loss of body weight more 10%, chronic diarrhea during 1 month and more, constant or intermittent fever within a month. Small signs: cough more a month, generalized itching dermatitis, herpes zoster in anamnesis, candidosis of mouth cavity and pharynx, chronic progressing or disseminated herpetic infection in view of herpes simplex with stable course more than 1 month, associated with absence of reasons for immunity depression, and generalized lymphadenopathy. Criteria for laboratory investigation on AIDS. First, motiveless decrease of body weight more than 10%. Second, lymphopenia of unknown origin. Third, frequent infections. Fourth, presence of risk factors if your haze, addicts, street walkers. Cutaneous manifestation of AIDS may be in view of infection dermatosis and non-infection dermatosis and neoplasms. Infectious dermatosis include seborrheic dermatitis, lichen, herpes zoster, molluscum contagiosus, papillomaviral diseases, hair leukoplakia, candidosis of mucal cords and perianal skin, deep mycosis. Non-infectious dermatosis may be in view of vascular affections, multiple telangiectasia, and hemorrhagic vasculitis. Psoriasis, ichthyosis, onychomycosis, rashes and toxicodermia. And neoplasm affecting of skin may be in view of Kaposi sarcoma, B-cellular lymphoma. Surgical masks of AIDS. The peak of AIDS is accompanied with some signs similar with surgical pathology. Long high fever up to 39 degrees may be assessed as usual bacterial or viral infection, sepsis, chronic purulent syndrome. Lymphadenopathy, stable enlargement of lymph nodes may be assessed as lymphogenitis, Hodgkin lymphomas, lymphomatosis, Lewis. Long diarrhea may be assessed as intestinal infection, chronic colitis, or enterocolitis. Frequent infection of respiratory tract, herpes, bronchitis, pneumonia on the background of post-operation period. Frequent purulent diseases of skin, boils, furunculosis, pyodermitis. Occurrence of tumor on skin of lower extremities with possible ulceration, Kaposi sarcoma. May be assessed as trophic ulcer and thrombophlebitis. Other indicator diseases. Very distributed indicator candidosis of different part of gastrointestinal tract and bronchi. Trachea, bronchi, esophagus, lungs. Extrapulmonary candidosis. Cryptosporidis with diarrhea lasting more than 1 month. Cytomegaloviral infection of any organs in patient after 1 year old. A herpetic infection with ulcerative damage of skin of mucous cords lasting more than 1 month. Kaposi sarcoma in elderly patient before 60 years old. Lymphoma of brain in elderly patient. Lymphocytic interstitial pneumonia or pulmonary lymphoid hyperplasia in children before 13 years old. Disseminated mycobacterial infection. Pneumocystic pneumonia with involvement of lymph nodes attached to pulmonary root. Progressing multifacial leukoencephalopathy and toxoplasmosis on central nervous system in patient after 1 year old. In upper picture we may see computer tomography of cerebral tomogram showing appearance of leukoencephalopathy in patient with AIDS, and lower picture demonstrate radiograph appearance of lungs following lines of skin infected with pneumocystic carini in patient with AIDS. AIDS problems for surgeon. Surgical aspects of treatment of malignant tumors specific for manifestation of AIDS. Urgent surgical aid to AIDS patient. Prevention of professional infection. And AIDS and blood transfusion. According to data of United States Public Health Ministry, a part of sick public health workers among HIV infected, not less 6%. More often, nurses and junior nurses get sick, up to 80%, doctors 20-25%. But risk of infection of surgeon within surgery is higher than for surgeon's assistant and nurse. The most rate in thoracoabdominal surgery, obstetrical and dental departments. Obviously, getting blood on surgeon's skin is less dangerous than damage with picking and cutting tool because blood may penetrate into deep tissues. The most frequent, up to 84%, and the most dangerous factor of risk, deep prick by needle or cut by scalpel wound accompanied with bleeding, and rarer 13% entrance for infection is superficial wound with insignificant bleeding. Less probable, in view of 3%, infection occurs after getting biological fluids on non-damaged skin and mucus. Great importance belongs to dose of blood and other biological fluids and concentration of viruses. 1 milliliter of HIV infected blood may contain up to 1,000 of infecting doses. Amount of blood sufficient for HIV infection is 0.5–0.001 milliliter. A doctor may be infected by blood within immunological window when patient is contagious, but markers of viral infection are not revealed. Probability of infection from seronegative patient is 0.001 up to 0.0001%. Probability of HIV infection for doctors of surgical department after single pricking is 0.1–0.5%. Forecasted risk after 30 years of work 0.5% if level of distribution of AIDS is stable and special protection is provided. Principles of non-specific and specific prophylaxis. Thorough following algorithms of invasive medical manipulation. Using uniform and special protective appliances. Plastic screen, glasses, double gloves, waterproof surgical cord. Avoid using special stitching apparatuses to apply sutures between whole organs. Non-contact and distant surgery when surgeons don't contact with patients' tissues due to tools, devices, and robots. Risk of HIV infection is decreased for 70–80% by antiretroviral drugs within 24 hours after damage. This is a measure of demonstration of measure prevention of AIDS infection in surgery. Double latex surgical gloves, the element of surgeon's protection. Lightweight mask that can be used for protection of eyes when operating on patient at high risk of HIV infection. Thanks for your attention. Good luck. See you in a week.